before I get started, I'm part of Capitol Health Gastroenterology Specialists. We recently moved the practice to Bordentown. We have nice brand new building. It's really big. It's across from Team 85, but on Route 130, but northbound side. Our phone number is unchanged, and I've listed the address and phone number right here. I work with 3 physicians, Dr. Mark Saxena, Dr. Michael Aditieri, and Dr. Wasim Butt. And we see patients with a variety of conditions such as gastroesophageal reflux or GERD, irritable bowel syndrome or IBS, as we're going to discuss today, chronic constipation and diarrhea, celiac disease. We do colon cancer screening and surveillance. We treat patients with gastrointestinal bleeding, chronic liver disease such as non-alcoholic fatty liver disease or hepatitis C, inflammatory bowel disease like Crohn's or ulcerative colitis, and our physicians perform endoscopies and colonoscopies. So getting back to today's topic, irritable bowel syndrome, I'll also be referring to it as IBS during the presentation. American College of Gastroenterology defines IBS as a chronic condition that affects the bowels and how they work. So people with IBS have abdominal pain that is associated with altered bowel habits, constipation, or diarrhea. The good news is that even though irritable bowel syndrome can be very bothersome, it is not dangerous. It does not increase the risk for colon cancer. It does not cause any damage to other parts of the body, and it does not reduce one's life expectancy. So who has IBS? IBS is actually fairly common. It's in about 10 to 15% of the general population, which is about 35 million Americans. IBS can happen at any age, male or female, but it tends to be a little bit more common in younger females. Sometimes IBS can be associated with other conditions like muscle aches, fibromyalgia, anxiety, depression, reflux, chronic fatigue syndrome, bladder spasms, or difficulty with urination. So again, IBS does not increase the risk of cancer or cause organ damage, but IBS can be very significant. There's a huge impact of IBS in terms of how it affects an individual. People can miss days of work. They can visit the emergency room multiple times. And there's significant healthcare costs associated with irritable bowel syndrome. In fact, it's estimated that a $1.5 to $10 billion per year in the US alone is related to unnecessary or too frequent testing, imaging, or surgeries for irritable bowel syndrome. And a study found that the majority of IBS patients would actually accept a 1% risk of death or 10 to 15 years off of their life expectancy if they could find an instant cure for their symptoms. That's pretty significant, and that kind of highlights the severity of symptoms in patients with irritable bowel syndromes and the marked reduced quality of life that some people with IBS can experience. So how is IBS diagnosed? So irritable bowel syndrome is a functional disorder of the GI tract. It's considered a gut-brain disorder. Unlike organic disorders, which have a simple diagnosis and a test, IBS is more of a collection of symptoms that act in a certain way. So we have, I don't want to get too technical here, but it's important to kind of highlight that for clinicians, we use the Rome-4 criteria. So we look at chronic or recurrent abdominal pain and altered bowel habits for at least 6 months. And then we take a look, does the abdominal pain happen at least once a week over the past 3 months? And you need 2 of the following criteria. The abdominal pain should change with the bowel movement. So having a bowel movement may make the pain better, or having a bowel movement may make the pain worse. And then there's a change in the bowel movement. So there's a change either in the consistency of the stool or the frequency of the stool. And, a lot has changed for irritable bowel syndrome. Now it's recommended that we use a positive diagnostic strategy. That basically means when we're with patients, we want to get a careful history, physical exam, use some standardized IBS criteria like the Rome 4 criteria. And then in the absence of any alarm symptoms, we start treating patients with suspected IBS right away. This eliminates, delayed care and can offer patients potential management options sooner than later so they start feeling better. If there are alarm symptoms, obviously we look into that further. And, even though we start treating for irritable bowel syndrome right away, we also consider other potential causes of patient symptoms. So other potential causes can include infection. So, it's important to know if somebody's traveled or has been around sick contacts. We evaluate for celiac disease. Celiac is a form of gluten intolerance. It's not very common. It happens in about 1% of the population in North America. And it can be evaluated with a blood test. Actually, all of the conditions that are listed right here can be evaluated, at least initially, with non-invasive testing, which is really nice. Again, looking to create less cost, but also more efficiency within the healthcare system. You also evaluate for lactose intolerance. This can be done with a breath test, although, unfortunately, that's not widely available. But the most simple way and most effective way of evaluating for lactose intolerance is actually just trying a lactose-free diet for a week and, assessing for symptom improvement. We also look for pancreatic insufficiency. If patients have certain things in their history that may make us suspicious for that, that can be done with a stool test. And then again, certain things in the history may make us want to look for inflammatory bowel disease. So that's Crohn's or ulcerative colitis. And that usually starts with a stool test and blood work. And then if those come back suspicious, then we would proceed to further testing like a colonoscopy. So let's talk about the symptoms of irritable bowel syndrome, and we can kind of break them down. So abdominal pain. Abdominal pain is a prominent, bothersome symptom of irritable bowel syndrome. The pain can be of any quality. Many patients describe it as cramping, but it can be anything. It can be stabbing, burning, aching, again, any quality of pain. And it can occur anywhere in the abdomen. It can be lower abdominal pain, it can be upper, it can be around the belly button, it can be all over. And the pain can change location and it can change quality. So you may have pain one day on the lower right side, maybe that's more aching. And then another day you could have pain maybe on the upper left side, and that's more cramping. This makes it a little bit difficult, again, for some people to diagnose, which was why we go back to that Rome 4 criteria and really take a look at how these symptoms interact with each other and tease out a pattern. Pain can be associated with abdominal bloating or gas. And if the pain is really bad, sometimes people are nauseated or can even vomit. But again, it comes back to pain is associated with bowel movements. Bowel movements can either make the pain better or make the pain worse. Even if it's temporary improvement, even if it's minor improvement, it still counts. Pain can also be associated with stress. So in times of increased stress, anxiety, depression, the pain can become worse. And then pain is sometimes associated with meals. So it may have patients say, after eating, I feel pain. And it could be, not only just after meals, but after ingesting certain types of foods. And we'll talk about dietary factors a little later on. So, we talked about pain, we talked about change in bowel habits. So patients can have constipation or diarrhea. Irritable bowel syndrome with constipation, or IBS-C, is one of those types. Constipation means different things to different people. Not necessarily spending a long time in the bathroom. This gentleman here in the picture seems to be taking advantage of some alone time, catching up on his reading. Maybe he's hiding from children who are home during the pandemic. But constipation traditionally means a long time between bowel movement, at least 3 days or more. It can refer to hard stools or the stool consistency itself. So I have a little chart over to the right side here. This is a Bristol stool chart. I actually love using this in the office because it really helps. Not everybody is comfortable talking about their own bowel habits. Sometimes people have a little bit of difficulty describing their stool. I've seen pictures on people's cell phones, and that's fine, but this tool is really great for standardizing the process. So constipation here would be type 1, 2, or 3. I've highlighted that with a red circle. So type 1 would be hard, small pellets. Type 2 is more hard and lumpy, and type 3 is formed but with cracks. So all three of those types can represent constipation. Constipation can also be manifested by straining for a bowel movement, or once you have a bowel movement, feeling like you're not completely empty. Sometimes constipation requires manual maneuvering to pass a bowel movement. So all of these things can be included with constipation. And one type of irritable bowel syndrome is irritable bowel syndrome with constipation. Another type of irritable bowel syndrome is irritable bowel syndrome with diarrhea, or IBS-D. So we look at the diarrhea. So the time frame for irritable bowel with diarrhea, we want to have at least 4 weeks of diarrhea, so chronic diarrhea. If it's less than 4 weeks, it may be related to other causes. Again, as we discussed, evaluating for other causes could include making sure that somebody doesn't have an infection. Stools can be loose or watery. So again, using our Bristol stool chart to the right, diarrhea would be type 5. So that's soft stool. Type 6, which would be mushy or loose stool, or type 7, which is watery stool. Then we can also take a look at when the diarrhea is occurring. So in IBS-D, diarrhea happens pretty much during the day. If you're waking up at night to move your bowels, this can indicate another condition that's not irritable bowel syndrome. That would have to be evaluated further. Now, it doesn't count if you're waking up for other reasons, if you're having trouble sleeping, or maybe you get up at night and go to the bathroom to urinate and you're having some stool at the same time. This would be waking up from a deep sleep to move your bowels. Again, that's considered an alarm symptom, and we have to take a deeper look into that. With irritable bowel movements are usually not bloody. Blood in the stool, again, is another alarm symptom that would have to be evaluated further. It could be something minor, like hemorrhoids, but it could be related to other causes, in which case, again, a clinician would have to further investigate. And then there are two other types of irritable bowel syndrome. One is irritable bowel mixed type. That's where you get both constipation and diarrhea. It can toggle between the two. And then you may have no specific change in bowel habits. And that's irritable bowel syndrome unsubtyped or unclassified. So in those patients, it's not as common, but in those patients, you would still have the abdominal pain. but the pain would change with the bowel movement. So even if you are not having constipation or diarrhea, I'm going to toggle back to the Bristol stool chart here. This would be type 4, right in the middle is the ideal stool. Soft, smooth, formed, easy to pass. So in IBS-U, patients may have normal stool, but again, their abdominal pain is still changing with the bowel movement. And irritable bowel syndrome, as I had mentioned before, not only is a mix of abdominal pain, constipation, diarrhea, but is often associated with other symptoms. Abdominal bloating is very common. This can include gassiness, either passing gas from above with belching or gas below, flatulence. Sometimes people may experience reflux symptoms. That could be heartburn or feeling like food or acid is coming back up in their chest or throat. And then again, some patients experience nausea or vomiting, especially if the pain is severe. So before we talk about potential management options for irritable bowel, it is important to kind of get a better sense of potential causes of irritable bowel syndrome. So like I had mentioned before, irritable bowel syndrome is not an organic disorder, it's a functional disorder, a gut-brain disorder, if you will. There's no clear-cut cause of irritable bowel. We're not entirely sure why some people get irritable bowel syndrome and some people don't. But there are some schools of thought out there. So one possible reason is that people with IBS have a visceral hypersensitivity. That's a fancy way of saying that people with IBS are more sensitive and more responsive to signals in the GI tract. So normal signals could be perceived as pain. So to an average person, the inner workings of the GI tract just go on and that person's not aware. A person with irritable bowel is more sensitive to the normal ongoing in the GI tract, and then they feel pain. In addition, if there is pain, they perceive that pain much more strongly than the average person. So that's one potential theory, and we'll touch on that a little bit later as well. Then again, irritable bowel syndrome is a disorder of the gut-brain axis. So in times of stress, anxiety, depression, anything that's going on in the brain is exacerbating GI symptoms. Again, there's millions of neurons in the GI tract and it's all connected. If you ever think about people saying, they get butterflies when they feel a certain way, or nervous about, going on a date or doing a presentation or something in their lives, and maybe they feel abdominal pain or they feel, okay, I'm really nervous, I have to run to the bathroom. That's kind of along the same idea of this gut-brain connection. Then there's something that's a little less common, but it's called dysenergic defecation. So this is seen more with irritable bowel syndrome with constipation, but it's actually having the anal sphincter and the pelvic floor not being able to fully relax to pass the stool. And because of that, you're getting some constipation. And we'll touch on that in a little bit as well. Finally, another theory has to deal with the microflora. So the GI tract has billions of bacteria, and most of that bacteria is good. We need that bacteria to carry on our everyday bodily functions, helps us break down our food. One potential theory is that the microflora in our GI tract is set off balance in people with irritable bowel syndrome. So the bad bacteria is almost overgrowing the good bacteria. Sometimes this is seen if people have had a lot of antibiotic use or if they've had a certain type of infection. And it's usually seen more with people who have irritable bowel with diarrhea. Now we can start talking about, we've talked about the symptoms, we've talked about what they mean, we've talked about how to rule out other causes. Now let's talk about what we can do for people with irritable bowel syndrome. So main part of management is treating the symptom. So for constipation, we kind of take it in a stepwise fashion. Want to make sure that people are drinking enough water. It sounds so simple, so basic, but a lot of people are not getting the ideal 8 to even 12 glasses of water a day. And that can significantly contribute to constipation. We also want to make sure that people are eating enough fiber, especially soluble fiber. And I'll talk about fiber a little bit more in greater detail later on. So not only do we want people to eat lots of fresh fruits, fresh vegetables, whole grain foods, and beans. Those are all high fiber foods. If that's not enough, then we go a step further and actually add in a fiber supplement. There are a lot of different options out there. There are fiber that comes in powder, and you can add that to a liquid and drink it. There are fiber gummies for people who don't like the powdery texture, and there are fiber tablets as well. And then again, going in that stepwise fashion, if that's not doing the trick, we start exploring certain laxatives. There's some over-the-counter laxatives that we look at, and then there's also prescription medications. Like I had mentioned before, some people who have constipation have this dysenergic defecation where they're having trouble with the pelvic floor and the anal sphincter, in which case we could consider referring for pelvic floor biofeedback therapy, working with a special kind of physical therapist to learn how to strengthen and then relax the pelvic floor. And finally, this is a simple intervention, but it can be very helpful, is using a squatty potty or a footstool. So the purpose of that would be to elevate the feet during the bowel movement for optimal positioning. It changes the alignment and allows for easier passage of stool. So those are all things that we think about for patients who are experiencing constipation. For people who have diarrhea, and this can also fall into the category of people who have irritable bowel syndrome mixed type, so constipation and diarrhea, we would use some of both of these strategies. But for people who have diarrhea, we would want to rule out other causes like lactose intolerance. So, again, this is a pretty simple intervention. It doesn't require any testing, but we recommend a lactose-free diet for 1 week. So, avoiding high lactose foods and beverages like milk, soft cheese, or ice cream. Milk is obviously very high in lactose. The softer the cheese, the more lactose it contains. So soft cheese like mozzarella, ricotta, cottage cheese, they have much more lactose than a harder block cheese like cheddar. Cheddar would have little to even sometimes no lactose. Yogurt has lactose in it. Some people are okay with that, some people are not. So again, trying just for a week to see if there's any symptom improvement with the lactose-free diet, because that's an easy thing to try and it actually ends up helping a lot of people. And we would also, look into other potential causes, depending on people's risk factors, but potentially evaluating for celiac disease. Again, that would start with a simple blood test. For diarrhea, some patients can benefit from fiber. Certain types of fiber are really good at bulking the stool. And so that would, be particularly useful if you're having very loose or watery stools. Sometimes that also helps if people are having a little bit of fecal incontinence as well. We had talked about one of the potential theories of irritable bowel syndrome being this microflora imbalance. And this is where the role of probiotics could potentially come into play. This is an area of further research right now. It's actually very interesting. But adding in the good bacteria, either with a probiotic food like yogurt or sauerkraut or kimchi, or a probiotic in the pill form is often helpful for patients with IBS-D. There are a couple of different prescription medications for diarrhea that can be explored as well. And I will be discussing this in greater detail shortly, but dietary modifications can also help. There's an irritable bowel diet, and there's also a low Fodmap diet. I'll touch on the diets in just a moment. And then finally, for abdominal pain, sometimes if we are able to treat the constipation and treat the diarrhea, the pain also gets better, which is really nice. Other times it's still there, so we need to look at additional options. For people who have pain associated with abdominal bloating, we also want to address the bloating component. Sometimes that means going on a low gas diet. Other times it means taking medicine like an anti-gas, so something like a simethicone or a Gas-X. There's been more studies into the natural option of peppermint oil. Peppermint oil can work in a couple of different ways. Peppermint oil helps relax the muscles of the GI tract, which is useful if people are getting some kind of like bowel spasm. And it also helps to decrease pain sensation. For people who have irritable bowel syndrome and some degree of reflux, they may benefit from a peppermint oil that actually comes in a coated capsule. So there's specially coated capsules of peppermint oil that don't open up in the stomach, because peppermint can sometimes contribute to reflux, but rather it opens up in the intestines and is working on that process at that location. Again, more treating the irritable bowel component of things and avoiding potential reflux. And there are a couple different brands out there. One of them is the letter I and the letter B and then GARD, but it's spelled G-A-R-D. So that's a coated peppermint oil that's out there. Sometimes people benefit from a standalone medication for the abdominal pain, like an antispasmodic, and they can get this from their primary care doctor or their gastroenterologist. And then I talked about prescription medications for constipation and prescription medications for diarrhea. A lot of those medications do address the pain as part of their component. And then again, coming back to dietary medications, the irritable bowel syndrome diet and the trial of the low Fodmap diet. I don't want to get too technical, but I think it is important to review this. Fodmaps are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So those are certain carbohydrates that are poorly absorbed and harder to digest in certain people. They pull water into the GI tract and they ferment, and that causes symptoms in some people, especially people with bowel syndrome. There are a number of different high FODMAP foods, and I have a chart right here. You can also look these up. Highlights include apples, watermelon, pears, high fructose corn syrup, and lactose products, certain vegetables like beets, cabbage, or onions, wheat and rye products in large amounts, certain beans, and artificial sweeteners. You may notice that some of these foods are actually in multiple categories. So again, how do these FODMAPs cause symptoms? The FODMAPs are harder for some people to digest and absorb. So people who are sensitive to FODMAPs have more FODMAPs reach the large bowel, again, because they're harder to absorb, so more reach the large bowel, and they end up causing more symptoms. So again, if you remember, we talked about visceral hypersensitivity. People with irritable bowel can feel things more than people without irritable bowel. So you're getting some bloating and some bowel contractions from the FODMAPs. People with IBS are getting more FODMAPs into the bowel, and they're feeling these changes more acutely. Then again, it is important to note that everybody is different and not everybody will have these symptoms. So again, when FODMAPs are in the large bowel, they pull water into the bowel. When you have extra water, you can have bloating or distension. This is why some people may say, I feel like I'm really bloated. Or they may say, I look like I'm 6 months pregnant. That's more the distension that they're getting. When you have more water coming into the bowels contract. That can cause pain. And when you have this contraction and this spasm, that can cause some diarrhea as well. And then if you think about it, water mixed with stool can also cause diarrhea. So that's one way certain FODMAP foods could potentially cause symptoms. Another way is the FODMAPs ferment. So they're broken down by the bacteria in the bowel, and that produces gas. So again, similar idea. Gas leads to bloating and distension, which causes pain. Gas can stimulate the bowels to contract. Again, pain and diarrhea. And then that extra gas can be noisy. Even if people are not passing the gas, they may say, I can just be sitting there after a meal and my stomach is so loud, somebody sitting next to me or the table next to me can hear it. And it's really embarrassing. That's something that can be going on. And then, in addition to that noise, people also pass the gas. So you can have a lot of flatulence. And I've had people say, it's smelly or it has an unusual odor. And, and unfortunately for many people, all of these symptoms can be really bothersome and really embarrassing. So what can we do about it? So there's a low FODMAP diet. This gets a little bit tricky, but the basic idea is to go back to that chart and eliminate foods that are high in FODMAPs. If you feel better, most likely you're sensitive to at least one of the FODMAPs. But we don't want to keep people on this very restricted diet for long. We want to reintroduce the high FODMAP foods, but we do this in a systematic way. We want to introduce one group at a time over several days and keep a food journal to see which high FODMAP foods and in what amount could cause symptoms for an individual. So somebody may be okay, apple was one of the items listed. Somebody may be okay with a small amount of apple. It may cause them no symptoms, but maybe they have a whole apple or 2 apples and then they're feeling symptoms. So that would be, how the process would go. They would be okay. They can have apple in moderation, but they would avoid large quantities. It does get a little bit tricky. The diet is very restrictive. Again, it requires a lot to eliminate the high FODMAPs and then gradually reintroduce over time and track symptoms associated with each food and food group and in the different amounts. So we often recommend working with a dietitian for this. But again, keeping in mind that our goal for all of this is to identify the few trigger foods so that you're not having a very restricted diet. for the long term. And actually, sorry, going back, incidentally, studies have shown that about 70% of people who try this low FODMAP diet to identify their triggers, about 70% of people have symptom improvement. So it's actually a really great tool to use. And then we could talk about general options. Again, there's a general irritable bowel syndrome diet. So it's recommended that people have regular meals throughout the day, not going too long between meals, and the meals that they are eating to be in a moderate portion rather than a large portion. There's areas of ongoing research. There's an unclear role for the following. Lower fat. So the idea is that fat can slow down the small bowel motility. This could potentially lead to gas and bloating. So it's been suggested that people do not exceed 40 to 50 grams of fat per day. Again, we need a little bit more data to see how that directly impacts people with irritable bowel. It's also been suggested to eliminate caffeine. So caffeine can increase gastric acid. It can increase colonic motility. So it's recommended to keep about 400 milligrams a day or less. It's actually about 4 cups of coffee or less. So it's still a lot, but you have to see how you feel when you have caffeine. And if you've noticed, you're okay with 2 cups, but 3 or 4 kind of causes symptoms, then you'll want to avoid that higher amount. And then again, there's limited evidence in terms of alcohol consumption. There's some suggestion that people who binge drink or use a little bit more than moderate alcohol at any given time can have increased GI symptoms, but again, unclear role. The important takeaway with all of this is, even though evidence for those things are limited, spicy foods as well, it's important to pay attention to your symptoms. So if you notice after certain high-fat meals or spicy meals that you're getting a lot of symptoms, you'll want to stay away from those things. And I'll talk about this next, but in the IBS diet, we want to have more fiber, specifically more soluble fiber and less insoluble fiber. And then also follow a low gas diet. So for fiber, there's different types of fiber. There's soluble fiber, which mixes with water to form a gel. And this helps slow down digestion. That allows for our bodies to absorb nutrients, and it's good for the bowel. Insoluble fiber is also beneficial in its own way. It does add some bulk, but it can be stimulating. So it's recommended for people with IBS to have more of the soluble fiber and less of the insoluble fiber. So I have some pictures here, but foods that are high in soluble fiber include flaxseed, chia seeds, oat bran, barley, nuts, seeds, beans, many fruits, celery, carrots, and peas. Foods that have a lot of insoluble fiber include whole wheat, whole grain, zucchini, green beans, and cabbage. So bottom line, both fibers are healthy. They are both good for us, and they each have their own role. But for people with irritable bowel syndrome, often benefit by increasing soluble fiber and decreasing insoluble fiber. So anytime we're increasing fiber in our diets, it's very important to drink more water. Again, fiber pulls water into the colon. It allows for a formed bowel movement, but it's also soft and easier to pass. But if there's not enough water in our bodies to pull from, extra fiber can cause bloating, abdominal discomfort, a little bit of GI upset in terms of gas and nausea. So, again, increasing the soluble fiber, but also increasing the water intake, at least 8 to 12 glasses a day. And then the low gas diet is the last part of the IBS diet. So, trying to avoid gas producing foods. Some pretty common foods that are gas producing include broccoli, cauliflower, Brussels sprouts, onions, cabbage, carbonated beverages, beans, artificial sweeteners, lactose products, and chewing gum. Chewing gums often twofold. Most chewing gums are artificially sweetened, but also the act of chewing gum can allow you to swallow more air. You notice on some of these lists, we have some of the same food items. So we have lactose again here. Lactose was also a FODMAP, and then some people are lactose intolerant. So the symptoms could be caused from a number of different things. We also have artificial sweeteners on this list as gas producing, and artificial sweeteners were a high FODMAP as well. And then finally, we're wrapping down here to more lifestyle changes. So physical activity is great for people with IBS. You're more active, you get the endorphins flowing, everything is better when you have those endorphins, right? So if you move around a little bit more, you're able to get things moving in the GI tract, you clear the gas a little bit better. That helps bloating. If you're improving bloating, you're improving pain. If you're moving around more, you're improving constipation. Again, improving bloating and improving pain. And then to touch back on the psychosocial benefits of this, improved quality of life with exercise. You're not going to be as tired. It can help with anxiety and depression. Goals for exercise for people with IBS are light to moderate exercise, 30 minutes a day, 5 days a week. Could even be just going for a walk, getting outside, having some time for yourself, getting some fresh air. It is important to note that strenuous exercise may actually worsen IBS symptoms in some people because this can be a stress to the bowels. So you have to see how you feel as an individual. And then the last component is psychosocial. So stress management is huge with people with irritable bowel. That means different things to different people. Some people benefit from yoga, so you get the stress management plus the physical activity. Some people enjoy meditation. Again, with exercise, you're also setting aside dedicated time for yourself and making yourself a priority. Getting those endorphins flowing, that can help with stress as well. Some people also benefit from meeting with a behavioral health professional. There's certain gut-directed psychotherapies that can be helpful, or managing, underlying depression or anxiety. So going back to this gut-brain connection, if we do things to control abdominal pain, constipation, and diarrhea, if there's underlying psychosocial factors that are not being addressed, it's going to be really hard to get improvement in symptoms if we don't address these underlying issues. Some people may benefit from certain medications like tricyclic antidepressants, which actually help with the abdominal pain as well. So keeping in mind again that stress doesn't cause irritable bowel, it doesn't cause these symptoms necessarily, but it significantly impacts these symptoms and makes these symptoms worse. So in summary, irritable bowel syndrome is a multifactorial syndrome. It's a collection of multiple symptoms, again, abdominal pain, constipation, diarrhea, sometimes associated with abdominal bloating, potentially reflux, nausea, or vomiting, potential causes, we talked about the gut flora imbalance, the brain-gut connection, and the role of stress, as well as visceral hypersensitivity. Irritable bowel syndrome does have significantly lower quality of life for many people, but the good news, the silver lining is that it does not cause organ damage, it does not cause cancer, and it does not lower your life expectancy. And again, you know, with the positive, there are multiple options to manage the symptoms that IBS patients can experience, including a combination of diet, lifestyle, and medications. So thank you. That's my presentation. If you find that you yourself or somebody you know is experiencing problems with irritable bowel and you're interested in meeting with somebody to go over management options or have it further evaluated, you know, at the beginning of the presentation, I mentioned part of Capitol Health gastroenterology specialists. We have 4 providers who are all experienced in treating irritable bowel, so you can give the office a call and make an appointment if you'd like. And are there any questions?
Thank you, Lisa. There are some questions in the chat box. I don't know if you want me to read them first for you or if you want to read them.
Sure. Let me see if I can access the chat box.
And just a reminder to everybody, if you could complete the evaluation at the end, it is in the chat box.
So somebody had written here about diverticular disease versus irritable bowel syndrome. So, you know, there's diverticulosis, which is like little benign outpouchings of the colon, but I think this person may be referring to diverticulitis, which is where you get like an acute infection or inflammation of those little outpouchings. That would be something that's much more acute and could potentially be an emergency. So I mentioned the Rome criteria for irritable bowel syndrome, which is looking at pain that is chronic and a chronic change in bowel movement. So diverticulitis would be much more acute, much more short-term, and that would have to be evaluated urgently. For constipation, is a warm water enema a recommendation? Enemas can have their roles in certain situations, but that's not something that's traditionally recommended. You know, we tend to treat the constipation again in other ways. So increased water, increased fiber, over-the-counter laxative like a Miralax, which is not a stimulant laxative, but more of a gentle laxative, and then going a step further to prescription medications if needed. Will people be able to have a copy of the presentation?
And I did, I put Marsha's email there. So if anybody wants a copy of the presentation, email Marsha and she will look into it.
Okay, thank you. Is fecal incontinence an IBS symptom? So it would not fall within the criteria for IBS, but some people with IBS do experience fecal incontinence. I talked about the pelvic floor and dysenergic defecation. Sometimes pelvic floor issues can go the other way and lead to incontinence, in which case people may benefit from the pelvic floor biofeedback therapy. And sometimes if people are experiencing incontinence, again, going back to one of those bulking fibers, so something like a Metamucil could be very helpful. Why do gastro offices not want to reduce the size of fibroids extended outside? I'm not sure what this question is referring to, if it's uterine fibroids, in which case that sounds more of a gynecological issue. don't know if the person's able to clarify.
Hi, yes, that would be the anal fibroids, actually.
Anal
The
fibroids.
gastro offices that my husband's been through too, they don't even want to deal with it. They don't want to remove them. They don't want to reduce them. They just don't want to do anything with it. And I'm like, this is all part of the problems that my husband's having.
Yeah. You know, I don't have much to say about that. I think, you know, everything depends on an individual situation. Something like that could potentially be evaluated by a different specialty, even maybe a colorectal surgeon or a general surgeon. And then it would depend, you know, on the size, what kind of symptoms it's causing, and so on and so forth. But any anatomical difference around the anus can cause symptoms. Some people have perianal skin tags. Some people can get hemorrhoids. All of those things can cause irritation in bowel movements. Changes in bowel movements can further exacerbate that. At the bare minimum, trying to keep the area clean and dry, utilizing wet wipes, or sometimes even like a barrier cream can sometimes help in those situations. But you know, consider evaluation by someone in a different specialty too. Okay, so what's the difference between functional and motility disorders? So motility disorder could be something like gastroparesis, which is like a slowed stomach emptying that can be caused, you know, in uncontrolled diabetes, or if somebody is on chronic opiates, among other causes. Functional, this again is more of a brain-gut connection. So it has less of an organic cause, and it's not easily diagnosed with a test. So someone with a motility disorder like gastroparesis can be diagnosed with a test like a gastric emptying study. We talked about different potential theories of IBS. Again, there's no clear-cut cause. There is ongoing research. Is motility an issue in patients with irritable bowel? The answer is we don't know. That's an area of ongoing research. Any correlation between long-term use of proton pump inhibitors and IBS? That's an interesting question to see if it destroys the bad bacteria. I have not heard of an association between the long-term use of PPIs and IBS. Long-term use of PPIs can potentially increase ever so slightly your risk of, you know, certain types of GI infections like C. diff. That's a great question. You know, I think intestinal flora is this area of up and coming research, and you know, we're still learning things every day. I have not heard of that direct association, but again, you know, ongoing research into the role of gut flora. So how does fiber help with diarrhea? So we had talked about soluble fiber forming a gel. So if you think about diarrhea being loose or watery stool, if you're able to use fiber to kind of bind that helps with diarrhea. I don't know for the people out there who have ever used Metamucil. I've tried to give it to some patients in the hospital. Once you mix that powder with water, it forms a gel really easily, and you can turn that cup upside down and it's not going to come out. So, you know, it's along the same lines, you know, trying to bulk the stool.
Lisa, there's another question here. Anything about IBS related to having gallbladder removed?
Okay, sure. So, sure. So sometimes when you have your gallbladder removed, you can have issue with bile salt malabsorption, and that can cause diarrhea. Sometimes people who have gallbladder symptoms, you know, sometimes that's pain. Sometimes the pain can actually be some IBS pain too. So If you're having certain symptoms after your gallbladder is removed, specifically diarrhea, that may be related to bile salt malabsorption. And, you know, there's a certain medication that can work for that you can get prescribed. So eat something one time and it won't bother you, but you eat the same thing another time and you get diarrhea. So, you know, if you're consistently eating one thing and it's causing symptoms, that could be a FODMAP. If it's inconsistent, you know, it does sound like it could be related to diarrhea, but maybe not that specific. Sorry, it could be related to irritable bowel, but not that specific food. So trying to manage other factors would be important in this case. So, you know, managing pain, managing the diarrhea, evaluating for other causes of the diarrhea, and then coming up with a plan if you were to experience symptoms. So some of the medications like the peppermint oil or antispasmodics can actually be taken prophylactically. So some people will say, you know, I'm going out somewhere. I sometimes get a lot of abdominal pain after I eat meals. So I'm going to use this before meals, before I eat, to prevent the pain. Sometimes that has a role. Can IBS contribute to a partial bowel obstruction? Not to my knowledge, not to my knowledge.
Lisa, can you name the peppermint oil capsule that you mentioned
Sure.
earlier?
Sure. So one of the brands is called the letter I, the letter B, and GARD, but it's spelled G-A-R-D. So IB GARD. Let's evaluate. Okay. So, you know, for specific questions like that, you know, if you're on the Miralax and you're having stool coming out as you're urinating, so that would probably have to be evaluated a little bit further in more detail. So we'd have to see, are you having, you know, constipation and maybe you're passing some stool, but you're not getting all of it out. Some of it's sitting in the rectum. You know, again, it could be a component of dysenergic defecation if that's the case too. Or are you having too much of an effect from the medicine and maybe along the lines of diarrhea where, you know, loose stool and any trying to go to the bathroom again, urinate, you know, it's just coming out. That would have to be evaluated a little bit further to get more information into the history before I make specific recommendations. Thank you, Bob McHugh. Yes, IB GARD capsules. Long-term use of pre and probiotics affect IBSD. So again, you know, the role of probiotics is still unclear, but it is thought that yes, that could potentially be helpful in patients with irritable bowel syndrome with diarrhea. You know, it may not get rid of the diarrhea, but it may help. So are there any other questions?
There was another question. What is the Rome 4 criteria?
Oh, sure. So I had mentioned that earlier in the beginning of the presentation. Let me pull it up so I can say specifically. Actually, can I do screen share?
Yeah, you can still do it.
Let me just go back. So here you have the Rome 4 criteria. So looking at chronic and recurrent abdominal pain and or altered bowel habits for at least 6 months. The abdominal pain occurs at least 1 time a week over the past 3 months. And you want to have 2 of the following, either pain related to bowel movement. So again, that's pain that gets better or pain that worsens with the bowel movement. Doesn't mean that the pain goes away necessarily. And it can be temporary improvement or temporary worsening, but there's some change to the pain after a bowel movement. Change in stool frequency and change in stool form or consistency. So that's where we usually get the diarrhea and the constipation. keeping in mind that we had talked about the different components to the definition of constipation here: straining, incomplete evacuation, manual maneuvering, the hard stools, or prolonged time between bowel movements. It doesn't have to meet all of those, but any of those could indicate constipation. And again, the same criteria for diarrhea, so loose or watery stool. And again, more of a chronic thing here. That answers the question.
There's another question. Can change in brand of lactulose affect outcome for chronic constipation? It seems the new brand by pharmacy uses doesn't work as well.
So, you know, some people notice the difference between generic and brand names for any drug. I don't know what the other additives are. It's hard to say. Usually there's not too much that changes between brand and generic, even if there are a couple of differences in the additives. I'd say if you're finding a noticeable difference, maybe you can go back to the other. You know, it's important to note that lactulose can be very helpful for certain conditions, but if it's only for constipation, it can cause some gassiness and bloating. So you may want to talk to your provider to see if a different laxative like a Miralax may be better.
Can the pain be both cramping and or inflammation type pain?
Yes, the pain can change in quality and location, and it can really be of any quality. Somebody had mentioned testing for the small intestine infection. I don't see the original part of the question, but I think they might be referring to SIBO, or small intestinal bacterial overgrowth. So as part of the evaluation for irritable bowel syndrome with diarrhea, if somebody has had a surgery or an infection or been on antibiotics and they're having a lot of diarrhea and it's suspicious for irritable bowel diarrhea, one of the potential treatment options is to treat for suspected SIBO, the small intestinal bacterial overgrowth. And that goes back to the idea that the bad bacteria has outgrown the good bacteria. This is often seen in patients who have very watery stools, again, coming from the small bowel. There's a special antibiotic that can work on the intestines to reset the gut flora. So again, getting rid of that bad bacteria, and that's especially useful to have a probiotic in this situation to add the good bacteria back in. But that's something that can be evaluated further. I think that's what that person was referring to in the comment.
Does anybody have any other questions?
Yes, I do. Am I unmuted?
Yeah, you're unmuted. We can hear you. Yes.
Oh, okay. Yeah, I was the person that talked about the consult. My gastro guy has me on consult and Miralax and also a probiotic, and I haven't seen changes, but it was like I would go to the bathroom, I would have a bowel movement, and then later I drink a lot of water and I would go to urinate and some more of the bowel movement would come out, and it comes out each time. So are there any suggestions? I mean, I'm going to call him because this presentation was great, by the way. It really helped me understand a lot of the things, but I haven't seen any changes and it's been quite a few months for that. So any suggestions?
Yeah. So I don't know if it's perhaps you're not fully emptying with the first bowel movement, and it sounds like there might be some residual stool left in the rectum. So
Right.
maybe looking at the dosage of the medications that you're on, or adding in a fiber to help bulk that stool so you're able to have a more complete bowel movement when you're
Well,
moving.
that's what the Consul is a fiber supplement.
I'm sorry?
The Consul is a fiber supplement.
Now, is that like a psyllium fiber? I'm not familiar with that one.
Yeah, it is a psyllium fiber.
Psyllium. So you may benefit from increasing that a little bit.
Okay, all right, yes. But it's not a bad issue if this continues, right? I mean, of course, that you answered that with no cancer, no damage. So, I mean, if this continues, I mean, this could just be part of me for, who I am for the rest of my life, we're to say.
So unfortunately, irritable bowel syndrome is a chronic condition, but
Right,
it doesn't mean that you have to accept the symptoms. I think
right.
if you're having ongoing symptoms, you need to have them addressed. And, if one therapy is not working, you need to continue to make adjustments. You don't have to live with these bothersome symptoms.
Right. Yes, thank you so much.
You're
This
very
was
welcome.
this was a wonderful presentation. It really made me understand a lot more things. So thank you.
You're very welcome. Thank you. I'm glad to hear that.
Oh, and one other thing, did you say there was an email to somebody to get a copy of this presentation?
Yeah.
Yes, you can email Marcia. It's in the chat box. I can, if you want to write it down, I can give it to you now.
Oh, okay, yes.
It's-
Okay.
Okay,
It's M Rudolph, RUDOLPH at capitalhealth.org.
okay, thank you very much.
You're welcome.
Okay. Are ischemic colitis and IBS similar? No, those are very different issues.
Okay. Another question, any specific probiotic recommendation?
Sure. So there, again, we talked about different types of probiotics. So you could use a natural probiotic, which would be certain types of foods. So yogurt, Activia yogurt is really great. You can do sauerkraut or kimchi. If you're going to go with the pill form, we often recommend Align or Culturelle, and they have a number of different options, but those are two good brands. Someone raised their hand.
But there's another question here. Is there any correlation between leaky gut syndrome and IBS-C?
From my knowledge, no, and I think there needs to be more research into leaky gut as well. Is sugar bad for IBS? So it's hard to say it's something categorically bad. I think, if we were to go back to the FODMAPs discussion, certain carbohydrates, again, those high FODMAP foods, have the potential to cause symptoms in some people if they're consumed in certain amounts. So it's hard to say. That being said, foods that are higher in sugar, foods that are more natural sugar, like fruits, can have their own added benefit, whereas processed foods like baked goods would have some of the other items in them, potentially, those higher fat foods, the foods with less fiber, so they could potentially cause some extra symptoms. But it's hard to say, again, categorically good or categorically bad.
I have a question.
Sure.
Yes, I've had IBS for many years, and it causes a lot of stress and anxiety. I actually get an attack once I become anxious about going out to some routine things that never used to bother me before I had IBS, like going to a meeting or going to the store. So I was wondering, these medications, the tricyclic antidepressants, are they prescribed for people like me? And do they always cause drowsiness, or are there some that don't cause drowsiness?
That's a great question. I'm sorry to hear that you've been dealing with this for a while. So I think your question was a couple of different parts. So cyclic antidepressants can be beneficial for people who have some underlying depression or maybe even some anxiety, but are also experiencing a lot of pain. They can cause drowsiness. They're often taken at bedtime. They're often started at a very low dose. Again, you know, an evaluation has to be done with other medications that a person is on and other health conditions. It's often started at a very low dose and then gradually increased if needed. Again, only up to a certain amount. So yes, the dosing is much lower than the dosing for depression or other conditions. If you're finding that you're in certain situations that are always causing you symptoms, then you may benefit from meeting even with a therapist to do something like a cognitive behavioral therapy. If it's all situational based, and just kind of changing the way you think about things and approach different situations, and, you know, walking through different scenarios and what you do to kind of almost like reassure yourself that, you know, certain situations are okay, and hopefully, you know, preventing symptoms associated with that.
Right, thank you.
No problem.
Any other questions? Okay, well, if not, thank you, Lisa. Your presentation was excellent.
Thank you.
And if everybody could just complete the evaluation before you leave,